Go ahead, Linda.
Okay, thank you so much, Eric. I'm Linda Leskowski-Jones. I'm a patroller at Blue Mountain and a member of the Bear Creek EMS crew, conducting education. And I'm also a longstanding emergency and trauma nurse. I am joined with my husband, Larry. Just kind of pop in there. Yes. So Larry is going to be monitoring the chat as well. I tonight, we typically get a lot of comments, and we're going to be asking you for some of your feedback and your assessments as we go through to keep this presentation interactive. So if you have any questions, by all means, put them in the chat. We will do our best to answer those and also turn those over to Stephen Goldblatt, Dr. Goldblatt, and we will, I'm sure, have a great presentation tonight. So without further ado, I'm going to introduce Dr. Goldblatt. He is a cardiologist, a non-invasive cardiologist. He's been in private practice for more than 25 years. He is now retired from his office practice, but he still is engaged in hospital practice in cardiology in Connecticut. He is the medical advisor to Ski Sundown since 2020 in New Hartford, Connecticut. And he's also the regional medical advisor for the National Ski Patrol State of Connecticut Eastern Division. He is a medical officer team CT1 in the Disaster Medical Assistance Team. Last time, if some of you had joined us for part one, Steve talked about chest pain and assessment of a chest pain that was cardiac in origin. So he joins us for part two to talk about the other causes of chest pain. And without further ado, I will also, and let me just also mention Larry's a member of Blue Mountain Ski Patrol and also Bear Creek EMS. And we had an active day doing EMS kinds of things today. So unexpected EMS things. So Larry had a chance to practice his stop the bleed skills. So without further ado, Steve, take it away.
All right. Thank you, Linda. Thank you, Eric. Thank you, Larry. I'm happy to be here, and I'm happy to be presenting my second lecture through Bear Creek EMS. Tonight, as Linda had said, I'm going to focus on the chest pains that are not the result of coronary artery disease, myocardial infarction, and angina. And there is a large number of these conditions. And so when we talk about chest pain, everybody thinks, oh my God, it's a heart attack. But there are a lot of other conditions then that can cause chest pain. So first acknowledging that I am a clinician, but I also do like to get my hands dirty. It's nice to be in a warm, well-lit office, but being out on the scene is also vital. And so I acknowledge all of you in Ski Patrol and EMS for the service that you do, because I love being part of that and I love the camaraderie. And I'm a big fan of my patrollers at Ski Sundown and the state of Connecticut. So a couple of disclaimers. Uh, I'm providing education here, but I'm not providing education to turn you all into medical professionals. It's meant to be a thinking exercise. It's meant to be fun. It's meant to be learning, but this is not going to make you someone who can say, oh, you're having chest pain. I know what it is and I know what to do. So we always put that disclaimer in there. And as a reminder to that, we often don't know what the cause of chest pain is. So without a complete evaluation, including time in the hospital if necessary. So if somebody walks into my patrol shack and say they're having chest pain, I'm not going to sit there and figure it out. I am going to call 911. I am going to call for help. I'm not in a situation where I could properly care for someone who's complaining of chest pain. And so neither should you. don't take it upon yourself when somebody is telling you they have chest pain that you say, "Oh, Dr. Goldblatt told me what this is." I mean, I don't want that responsibility. So let's move ahead. And what I'm going to be doing tonight is I want to give you some assessment scenarios, and then I'm going to give time for you all to think about what the possible cause is. And then I will give the assessments, and as EMTs and ski patrollers, we are trained in the OPQRST, we're trained in the sample. I'll give you a little bit of an abbreviated, focused assessment of the individual, and then think about what you think is the diagnosis. Then I'll give a little bit more information. I'll show you an EKG. Uh, we have other imaging like chest x-rays, and then we'll talk about what the diagnosis is and what the causes are. I'm not going to get too much into treatment. That's a bit beyond the scope of what I'm shooting for tonight. I just really want to get you all familiar with a couple of the causes of chest pain, and it's pretty interesting. You can learn a lot about physiology and things that can go wrong. And so let's move ahead. So just a couple of anatomic terms. Most of you know what these are, but I'm just going, when somebody is having chest pain, if we're talking amongst each other, we like to give anatomic descriptors. So anterior is front, posterior is back, midsternal is center of the chest, substernal is behind the sternum. It's like deep to it's not at the level of the sternum, it's deep to the sternum. Peristernal is at the side of the sternum, mid-epigastric, kind of the point between the xiphoid process and the umbilicus. Precordial would be distributed across one side of the chest, and interscapular is between the shoulder blades. Infrascapular is below the level of the shoulder blades. So just a couple of anatomic descriptors. And when we talk about cardiac pain, these are a lot of the patterns that we see, and sometimes just a picture is better than a verbal or written description. So sometimes this is the easiest way to show the description of the discomfort. So, and this is with cardiac patients. They have different kinds of distributions of chest discomfort. In the ones that I'm going to be presenting, heart attack pain and cardiac pain, people have many different experiences. A lot of times, women will have atypical symptoms in different distributions, and they feel differently. Diabetics, the same. But in these chest pain syndromes that we'll talk about, they pretty much have a characteristic distribution and a characteristic pattern. So the OPQRST algorithm, I'm not going to get into this too much. You have been trained in this, so O is for onset. P is for provocation. A lot of these pains, that you want to know if they change with respiration or if they don't change with respiration, if they change with movement, body position. Those are some of the things that I would look for in the P, provocation and palliation. Q, quality, of course, all kinds of adjectives and descriptors. R, radiation, where does it start? Where does it go to? And with each of these conditions, there's some characteristic distribution of where the pain will radiate. S is severity, on a scale of 1 to 10, or 0 being no pain, 10 being the worst pain you've ever had. And I also use S as a landmark to think about symptoms. So when I'm thinking about pain, was there any symptoms that are associated with the pain, nausea, sweating, diaphoresis, dizziness. The other thing is signs. This will remind you to look at the patient. What's their, uh, how do they appear? Are they in distress? Are they in respiratory distress? Um, so signs is also something that will help when you're assessing these patients. T is timing, and T can also be treatments. What have they done? Have they have they used anything like warm or cold compresses? Have they taken any medications before you assess them? U is, I'm not really going to get into this, but U is for understanding, meaning what do they think it is? And sometimes that can provide a little bit of more information as to, well, I thought it was this because I was doing this and I felt this way, or it happened after a meal, or I've had this before and it kind of felt similar. So that's the U portion. And then sample, we pretty much have been trained in this, the signs and symptoms, which is pretty much covered by the pain assessment. Any allergies with heart attacks, clearly aspirin was one of the things that I would be focusing on. And also for heart disease, looking at risk factors, not as much of something I'm going to be focusing on in these chest pain assessments, asking about pre-existing medical conditions, when they last ate, and obviously any events that preceded the onset of symptoms and events that occurred have occurred during the symptoms themselves. So focused assessment, once again, look at the patients. Are they distressed? Are they pale? Are they ashen? Do they have a depressed level of consciousness? One thing in these chest pain evaluations is, what is their position of comfort? Can they get into a comfortable position? This will give you some tip-offs as to what it might be, and we'll get into that. Vital signs, whether they're stable or unstable, blood pressure, and for one of these diagnoses, it's real important that you check it in both arms, not just one or the other. Pulse, heart rate, respiratory rate, your vital signs, and then pulse oximetry. And what I'm going to invite, and Linda can help with this, is if people want a little bit more information, I can provide that and might help you formulate what you think is the diagnosis. One thing I also like to bring out is when you're assessing patients, one of the nonverbal ways that they'll communicate is with their hands. Are they holding a closed fist over the area of pain? Is there an open hand that's covering one side of chest or the other, or are they covering one of their shoulders? Is it just one spot? Are they pointing the finger just one spot? All these nonverbal cues help me get a more full assessment. And the challenge for first responders is you don't have a lot of time. So I'm trying to give you a quick encounter and let you all think about what this would be based upon the quick encounter. And then you might say, well, couldn't it be this? Couldn't it be this? Of course. There's lots of ways things present, and what I'm trying to do here is present some of the typical presentations. So first scenario one, 18-year-old female. She woke up this morning with some left lower sternal chest pain. Lower left parasternal would be another way to put it. It came on when she was sitting in class today. It was a little worse when she was twisting or laughing or coughing. All of those can increase it. The quality, it's sharp. She can point pretty much just to one area with a couple of fingers, just above the lowest ribs adjacent to the sternum. It's a low grade kind of discomfort, about 3 out of 10, but it's fairly steady. Um, it has been going on for the past 2 days. It's not going away, but it's not really getting worse either. Under sample, uh, we have the signs and symptoms already. She has no allergies. She's taking an oral contraceptive, no prior medical history. She ate a light breakfast. She skipped lunch. One thing in the prior events, she played volleyball 3 nights ago. She was in the interscholastic league. No injury, but she was active 3 days ago, and these symptoms started the following day. So the assessment, she's sitting quietly. She has unlabored respirations at 16, pulse 72. The equal should be under blood pressure, but the blood pressures aren't exactly equal, but it's 100/60 in the right arm, 108/60 in the left arm, and a 10-point blood pressure difference is normal between the arms. And is somebody on mute or not on mute? All right. And the bottom line is she can point to where it's located. So I always find that to be a reassuring nonverbal cue, and generally that would be though in more of the older individuals like me, where if they were to say, "Oh, it's just right here," I'm like, I breathe a sigh of relief and say, "Oh, okay, good." So this is a little bit of this is where the discomfort is located, to the left side of the sternum. And here is an EKG for those of you who know something about EKGs. This shows some ST elevation. And for those of you who are aware of EKGs, ST elevation can mean some worrisome diagnoses. And so your eyes might open up. One of the things that drives me absolutely crazy is when you have a young person, 12, 13, 17, 18, 20, and the computer, I'm sure you have all seen, or if you haven't, you probably will, seen EKGs, or if you have your my charts and you look at the interpretation, the computer will say ST elevation, consider acute myocardial infarction. So you've got a hysterical parent saying that their 14-year-old child is having a heart attack. Let me reassure you that this is normal in younger individuals. We call this early repolarization changes. Now, there is another diagnosis which can also have fairly diffuse ST elevation. The important thing is the story and the assessment. So this is important because you're putting together the assessment. So it's not just, I mean, if somebody was to hand you this EKG and told you nothing else, you'd come to probably a different conclusion. But this isn't the isolated aspect. And that's why getting a rapid, efficient story is helpful, and then put it together with these other modalities. And here is a chest X-ray. So let me reassure you, her chest X-ray is normal. But for those of you who haven't seen a chest X-ray, or who have seen what a normal chest X-ray looks like, these are some of the major anatomic landmarks that you would look at. And this will be useful because in the other forms of chest pain, you're going to see some abnormalities. The trachea, which is the clear pipe at the top, that's in the center of the chest. You have the right lung and the left lung. Now, you notice that you could see the ribs well, and you notice between the ribs that that's lung tissue, but it's not, even though it's air-filled, it's not black. It's kind of hazy. And that's because there are markings from the lungs, from the tissue itself, and from the blood vessels. So it will be kind of a hazy look to it. The heart is in the center of the chest, but as you can see, it sticks out a little bit into the left side of the chest. Normally, the heart's outer border, the lateral border, should be no more than halfway between the sternum and the outer portion of the rib cage.
Can I interrupt you, Steve, for one moment?
Yes.
We're seeing a comment that someone can't see the chest X-ray or the previous EKG. And I just wanted to find out, are others having that same issue with visualizing the slides?
Is there anything I can do on my end?
People are saying they can see both, but the person keeps getting bumped off, probably because maybe the storm's here. I don't know if they're in this area. No, everyone's also saying they can see everything. Okay, so it sounds like it may be an isolated problem. Thank you very much for answering that question. I just wanted to make sure that we can continue to enjoy this this presentation tonight. Okay, and someone's saying yes, it may be our connection. All right, very good. Thank you. Very sorry you're having that issue.
It says click Steve Goldblatt's screen at the top left.
Okay.
Are we okay?
Yeah, please go ahead.
Good to go. So the diaphragm, what you see is that it's the mark at the bottom of the lung. It marks the lower portion of the chest, and the diaphragms on both sides are roughly at an equal level. Usually the right one is a little bit higher because of the liver. The left one usually has a little clear spot, which is where the stomach is. We call that the gas bubble, and that's right below the heart. It looks a little bit clear. So just a quick, we were going to do poll questions, but we haven't worked out the software yet, so I'm just going to put these out there. So this is an example of what we call Tsetse syndrome, but what is the other name for that diagnosis? So is it gastritis, pancreatitis, costochondritis, pneumonitis, or bronchitis? This is the itis slide. So I'm not going to torture you because we can't collect all the answers. So it's costochondritis. So what is costochondritis? Which is probably one of the best things that you can have among all the chest pains where you can breathe a sigh of relief. Costochondritis comes from where the cartilage and the breastbone and the cartilage and the ribs articulate, meaning that they move. And if you don't have movement between the ribs and the breastbone, you can't expand your lungs, and then they can't contract. So it's a moving system. And so articulation and movement is very important. And so it's kind of like tendinitis or arthritis, except it's not arthritis, but it's like tendinitis. You've worked out, you've put a lot of strain on the chest, you've done a lot of pulling. And the other thing is, in younger individuals, they're growing. So sometimes the growth is a little asymmetrical. So that can cause a little malalignment, that can cause discomfort. But the bottom line is it's not serious, but it's more like the result of use and the result of probably intense activity, but it is not a sign of injury. It's not a sign of damage. So that's the red areas. It's the areas adjacent to the breastbone where the ribs and the cartilage move against it. It can also be a little bit on lateral, away from the breastbone, where the ribs and the cartilage also meet, because all of those areas have nerve endings, and pain perception is going to be something that is a little bit more definite in these chest pain assessments. in cardiac pain, the communication between the brain and the heart isn't great. So when you have someone who's having a heart attack or having angina, you're not going to say, okay, the pain it's in your left arm. Well, your heart's not in your left arm, but that's where your brain interprets it. With these chest pains, you're dealing with areas that do have a fairly rich sensory supply. So the pain is going to correspond pretty closely to where the issue is going anatomically. And one of the things to think about is that friction causes pain, and that's going to carry on into the next scenario. Any questions? Picking up anything, Linda? We're good.
Yeah, everything looks good.
Okay. So next one is a 21-year-old male who woke up with left precordial and mid-sternal chest pain. It was sudden. It woke him from sleep. It's worse when he's supine, and when he sat up, he felt better. Clearly, he said deep breathing makes it considerably worse, and he has to hold his chest, but that really doesn't help a whole lot, but it keeps him from taking large breaths. The quality is sharp. There's a catching sensation to the discomfort. It radiates to the neck and the upper back. It's not a catching sensation there. It's more of a burning sensation in that area. When he is supine, the discomfort is quite severe. He would rate it an 8. When he is sitting up, it goes down to a 3. And when he leans forward, it almost disappears. It goes to 0 to a 1. The timing, he had some mild discomfort yesterday morning, but it went away, but then it returned this morning. It was much more severe today. Under sample, he has an allergy to amoxicillin. He's on no meds. He did have a viral type infection about 2 to 3 weeks ago. He had a cough, he had a fever. He ended up going on an antibiotic, but it got better. But that was about 2 or 3 weeks ago, and nothing has happened in between then until yesterday and today. He had a sandwich for lunch, and once again, the events where he woke up from sleep with the pain, and as I said, it was milder the day before. So here's the rough pain distribution across the left chest and going up into the shoulders and the neck. And this is showing that it gets worse with inspiration, and the diagram gives you a little clue as to what may be causing this and what this is. So focus assessment, he is uncomfortable lying back and sitting back. He is much more comfortable leaning forward. Blood pressure is 130/90 in both arms. His pulse is 88 and regular. When he is lying back, it's very hard to take a deep breath, so they are shallow and fast. But when he sits up, it slows down at 18. He's still breathing a little fast because he's still having some pain, which is also why his blood pressure is a little bit high. Saturation, though, is good. It's 96%. Any other questions? Anybody else want to know anything else? It's okay if you don't. I'm just opening the door.
I'm going to ask one. So when
Okay.
you listen to his chest, what do you hear?
You hear some sounds. You might think it's a heart murmur. And when they lie back, you can hear it more loudly. When they lean forward, it almost goes away. So as you can see here, this person is leaning way forward to take care of, to kind of sit pain-free. And a lot of times this will be the position of comfort that you might see if you were to see a person sitting in the doctor's office or in the lounge. I'm not saying you're going to diagnose this in the lodge or in the ski patrol shack or somewhere else, but this is a position of comfort for this individual. Here's the chest X-ray. I will spare you a little bit of time to tell you that this is normal. And if you look on the right side, which is what we call anatomic left, you can see that little clear spot underneath the heart, and that's a gastric bubble. So that's where the stomach is located.
You may be able to use your pointer, your mouse, to actually point to things on your screen.
Oh, well, thank you. So there you go. So that is the gastric bubble. So once again, there's the heart, trachea, ribs, those the lungs with the lung marking, so it's not completely black. My mouse just decided to disappear. My arrow, there it is, just decided to disappear and reappear. So this is a characteristic EKG from this condition. For those of you who are familiar with EKGs, this is showing what is called diffuse ST segment depression. Once again, people worry that this could be a heart attack, but the important thing to point out is that in these individuals, as opposed to people having a heart attack, these individuals, every ST segment is elevated except for AVR, which is normally the opposite of everything else. So diffuse ST elevation, it also talks about PR depression, which I'm not going to get into, but this is your EKG. So diagnosis, once again, pneumonia, pericarditis, gastritis, pulmonary embolism, myocardial infarction.
So I'm seeing, is it GERD or reflux? Is the patient at sea level or higher? Gastritis. These are what's come into the chat so far.
Okay. So this is pericarditis. This is the classic pattern for someone who is experiencing pericarditis. So let's talk a little bit about what pericarditis is, because if you don't know what it is, you'll never come up with it as an answer to a diagnosis. So pericarditis refers to the sac that contains the heart. The heart is in the central chamber of the chest called the mediastinum. And within the mediastinum, there are several structures, which is your esophagus, your trachea, and your heart. And so the heart has a sac around it to protect it from the other structures. The pericardium, as I said, is central between the lungs, and it's in the mediastinum. The heart is contained within the pericardium, and it moves freely because the inner surface of the pericardium is nicely lubricated, and the outer surface of the heart is also lubricated. So normally when the heart is beating, it's two lubricated surfaces rubbing against each other, so that's why you don't feel your heart beating. So once again, the pain of pericarditis is when you're lying on your back. It brings the heart and pericardium in contact, and I'll explain in the next couple of slides why that's a problem. Sitting forward pulls the pericardium away from the heart so that the two of them are not in close contact. The motion of the chest by breathing aggravates the pain because when the lungs expand, they're pushing the structures in the mediastinum together. So you're pushing the heart and the pericardium together. And once again, they may be holding their chest, but it doesn't help. It just helps them take more shallow breaths, which causes less pain. So the pericardium, as I said, it's a lubricated sac encasing the heart. You can peel it away, and it's tough fibrous tissue, and there's different layers. There's a tough outer layer, and then there's a delicate inner layer which produces the fluid that enables the heart to move without pain. The inner lining of the pericardium has a lot of pain fibers, and so remember what I said. Certain organs have very rich pain and nerve supply, and the pericardium is one of those. So friction between lubricated surfaces, which are supposed to be lubricated but have developed friction, causes pain. And it's caused by the loss or breakdown of the lubricant. In the pericardium, it's around the heart. In the pleura, which also is the similar encasing lubricated surface around the lungs. The peritoneum is a lubricated surface around the intestines, and the synovium are the fluid-filled joint cavity. So all of these are lubricated surfaces that enable movement without pain. Now, the breakdown of the lubricant occurs for a number of reasons. One of them is inflammation and infection. Another is damage to the lubricating tissue itself, or damage to the cells or the structure. Blood is a significant irritant. So if you have any blood in the pericardium, blood in your joints, this can cause pain because of the friction, the breakdown of the lubrication. In this person's case, the virus isn't what caused it, but there was an antibody. We think that there's an antibody response, and those antibodies attack the cells of the pericardium and causes inflammation, which breaks down the lubrication, and that's what's causing the pain. So sometimes when the pericardium gets inflamed, instead of becoming rough and dry, it can produce a lot of fluid. And the pericardium can become this fluid-filled sac where the heart is suspended within this pool of water, and the heart is swinging back and forth in this sac of fluid. And we call that a pericardial effusion. Now, if the pressure of the fluid is low, meaning that the heart is just swimming around in the fluid, you might pick it up on the ultrasound, but most of the time these people aren't even aware of what's happening unless they were to get a chest x-ray or unless something else was to happen. And that something else that happens is when the pressure in the pericardium goes way up and it compresses the heart. So I think probably most people are familiar with the term tamponade. So if the pressure of this fluid gets high and the heart gets compressed, it can't fill. And because it can't fill, blood can't get into the heart to be pumped out. And so that's why these people go into shock. They get critically low blood pressures because they can't take the blood in to pump it out. So that's pericardial tamponade. But as I said, people can be walking around with a pericardium full of fluid and not even be aware of it. So this is an echocardiogram showing that, which is a cross-section through the pericardium and a cross-section through the heart. Now, this was one that Linda was nice enough to share with me. On the left side, you see what is the normal heart border. And you can see it's halfway between the sternum and the outer portion of the chest. On the right-hand side, you've got this big sac that is extending all the way to the outer periphery of the chest. And this is what you would see in people who have a large collection around the heart. It just so happened that this was a trauma patient who suffered a stab wound. And this wasn't pericarditis. This was metal. No, this was a perforating injury to the ventricle causing exsanguination of blood into the chest. The only thing that saves a person's life if they get stabbed is that there's only so much blood that can leak into the pericardium and then it can't empty anymore. So these people, because if they don't go into tamponade, can survive with this blood being in their pericardium. They don't feel it because you're not having the two surfaces rubbing against each other. The heart is swimming around in a pool of blood. And as we all know, you don't want to pull out the offending object because in this case, if you pull out the offending object, all the blood will leak out of the pericardium and this person will exsanguinate. So any questions about pericarditis, pericardial tamponade? Do people understand how we came up with this diagnosis, and are there any questions?
I will add that stab wound was related to a fight between a man and a woman, and the woman stabbed the man. So, yeah.
Okay. Gender representation.
Mhm.
So number 3 is, oh no, we're gonna skip this one and come back to it just because I wasn't sure how much time we would have to. I'm giving you all the answers here. So scenario 4 is a 48-year-old female with sharp chest pain on the left side, and it's associated with shortness of breath. This came on suddenly. The patient was sitting on the toilet in the bathroom, and all of a sudden, this discomfort came on. It was sharp. It was worse with inspiration. It did not change with position. So it's pleuritic pain, but there's no positional component. It's sharp in stabbing in the area where it's being experienced. It has gone around to the back, kind of the mirror image opposite of where it is on the front. It kind of slowly came on. It's a 5 out of 10. But when you take a deep breath, that pain goes up to an 8 to a 9 out of 10. And it happened when she was straining on the toilet. It suddenly came on when she was straining on the toilet. All of a sudden it came on, but it also initially took her breath away, and then the pain came on after that. So that's the pain distribution. It's on the front and goes around to the back as well. And so sample, she's allergic to SOFA drugs. She is on hormone replacement therapy for menopause. About a year ago, she had a partial colectomy for colon cancer. The last meal she had was on a flight from California earlier today. And the events were that she had come home. She went to the bathroom. She had sudden onset of shortness of breath. And then I meant this, it should be left-sided chest pain, not right-sided chest pain. And then this is when the chest discomfort developed. So on exam, she has some respiratory distress. She has rapid, shallow breathing, respiratory rates 28, pulse is 110 and regular, blood pressure 100/60 bilaterally. Pulse oximetry is a little low, it's 88%. She is distressed. She is able to point to where the discomfort is, and she is clearly uncomfortable. There's no position of that's the most comfortable for her, but she is leaning forward because it's helping her take some deep breaths. But there's no true position of comfort for her. So if for those of you who know EKGs, this is a classic pattern, the S1Q3T3, and I apologize, I didn't put in a full EKG, but I'm throwing this there for people who have some EKG savvy, so you have the answer already. This is the chest X-ray. I am going to say that I am aware of the fact that on the heart side, the heart is a little bit closer to the chest wall than it should be. I would say don't pay attention to that. On the other side of the heart, these arrows are pointing to areas where it's not quite as hazy as it should be. And we call that loss of markings. Now, you're not going to see this frequently, and sometimes we would say you're using your imagination and telling yourself, oh, that's the way it should look. So let's just say I'm giving you that as a hint.
So we're getting a lot of comments in the chat around there was one person wrote pleurisy, or a couple people wrote pleurisy, PE. Several people wrote PE, and then, or did they throw a DVT and it's a pulmonary embolism?
Okay. So the diagnosis, is it pneumothorax? Is it foreign? I just kind of pulled these out of a hat, people. So there was no logic to this. I was just having fun. So pneumothorax, was there a foreign body, obstruction in the bronchus, bronchiolitis, pulmonary embolism, pneumonitis? And I think people have correctly pointed out pulmonary embolism. So where does a pulmonary embolism come from? One of the most common places is what is termed the deep venous thrombosis. Most of the time, this is in the lower legs. And this comes from pooling of blood in the lower extremities, particularly if you've been sitting or immobile for long periods of time. The blood clots and it doesn't move because you're not moving. And then after you get up and walk around, if you've been immobile for a period of time and all of a sudden you're walking and you're squeezing the veins, well, that blood clot will be mobilized and then head back up toward the heart. So that's what is causing the deep venous thrombosis. Now, there were a couple of other things that I had put in the sample that were what we call hypercoagulable states, meaning these things make blood more likely to clot. One of them is hormone replacement therapy, particularly in someone who is a smoker. They will be hypercoagulable. Cancer and recent surgeries can also make you hypercoagulable. So I was giving those just as little clues, but you guys are smart. I didn't need to give you all those clues. And so the way it happens is the blood clot in the vein returns to the right side of the heart, which is the side that pumps blood to the lungs. So that clot goes into the heart and then gets pumped into the pulmonary circulation, and it clots a portion of the lung. And where that clot is lodged causes kind of like a heart attack. It causes an infarction, excuse me, in the lung. And that actually is what causes the pain in a lot of these people, because it's inflammation. So once again, it's inflammation, friction, and the friction is what's causing the pain that these people experience from the pulmonary embolism. So the first thing they might feel, because it's lodged in the lungs, is shortness of breath, and then the pain may come later. So that's generally the progression of pulmonary embolism. Imaging, this is one of the things that a lot of people will get as soon as they come to the emergency room. They've gotten their EKG. One of the things that has to be ruled out is pulmonary embolism in people who are having chest pain. So people will have what's called a CT angiogram. And what happens here is you're going to have a CAT scan with dye injected into the bloodstream. And what you're going to follow in phased shots is where the blood is going. And in the center, the right ventricle is where the blood goes first, and then it gets pumped out to the lungs through the pulmonary arteries. And as you can see on the right side of the picture, you've got nice opacification, and that's a normal left pulmonary artery. But on the right-hand side, you see that big gray blob, and that's the thrombus. So this person has had a very large pulmonary embolism, not the person I'm talking about, but this is one of the ways that we image. Sometimes they actually literally will put a catheter up into the right side of the heart and up to the pulmonary artery and inject thrombolytic clot-busting medication if the clot is so big that it's putting the person into shock. This person, the blood pressure was borderline, the SATs were borderline, getting close, but not quite ready to have urgent treatment. Scenario 5, we're doing pretty good here. Scenario 5 is a 32-year-old male who presents with severe interscapular back pain, but it initially started as severe mid-sternal chest pain that had gone to the back. About 2 hours ago, he was watching TV. He developed this severe tearing chest pain, and it went into his chest, up into his throat, and then it ended up going into his back 30 minutes later. And that's where it's sitting now. It is very uncomfortable. It is unchanged with movement, with position, with respiration. Nothing makes it better, but nothing makes it worse. He just can't get comfortable. And he's only 32 years old. And it's like, this is scary. And the quality, it's just awful. It felt like something was tearing inside, and he is just in exquisite pain. And as I said, the radiation, but really it wasn't radiation, it was the actual focus of the pain itself, started from the front and then went to the back. And right now, his left arm feels cold and numb. And I said severity, it was an 11 out of 10 pain, cold sweat, nausea, almost passed out from the intensity of the pain. Once again, the timing, sudden onset, no warning, never had this before. This is going to be a little bit of a couple of interesting twists to this one. So this will be a little fun. So distribution of the pain, center of the chest, up into the neck, and then around to the back between the shoulder blades. Initially anterior and then posterior. Sample, aspirin is his allergy. He's on a blood pressure pill, so he has some high blood pressure. His father died suddenly at 30 from a heart attack, they say. But they don't really know. They just said, oh, this was a long time ago. He was 30 years old and he died of a heart attack, we think. He had a snack 3 hours ago. He had gone grocery shopping about 4 hours ago, and then the pain came on when he was just sitting. So, focused assessment, tall, thin individual. He's pale, he's sweaty, he's sitting, can't get comfortable, he's grimacing. Blood pressure is 180 over 110 in the right arm. It's 120 over 60 in the left arm. And the pulse is clearly weaker on the left side. Pulse is 112, respiratory rate is 28, but his SAT is 96%. So his oxygen level is adequate. Here's another thing that's part of the assessment. And you don't normally look at this, but here's just a couple of things. So he's got long fingers, he's got very flexible joints. And if that's a hint to any of you, well, I'll talk about it in just a little bit.
So a lot of people are saying AAA, and I see one individual saying Marfan's.
Oh, they're good.
Mhm.
Okay, yes, it's Marfan's. We'll talk about that in a little bit.
And of course, many are noting dissection with that AAA.
Okay.
Or aortic dissection.
Yes.
Rather than to be specific with abdominal aortic dissection.
Right. Right. So the EKG here, for those of you familiar with it, this is showing what's called left ventricular hypertrophy, meaning that the heart is thickened and it has characteristic changes in the QRS and in the ST segments. And it's called left ventricular hypertrophy, and it's an indicator of long-standing hypertension. So that this gentleman did have hypertension as one of his major conditions. So one of the things that we notice on the chest X-ray, and since everybody seems to be so smart, there's not too many people I'm going to surprise, but normally the normal cardiac silhouette is on the left side, and you see that nice indentation, and that's what's called the aortic knob. But in this condition, you lose that aortic knob, and it's a smooth contour from the top to the bottom. There's no notching there. So what organ system is involved? I think pretty much everybody knows that we've gotten ourselves into the vascular system. It's not gastrointestinal, pulmonary, neurologic, musculoskeletal.
There is one individual who's pointing out that also pointed out the conflicting blood pressures from the left to the right. And
yes,
important assessment finding.
Absolutely. Does that person have an explanation?
So that's a good question. Do you have an explanation? Or does anyone want to venture that? I'm not seeing that part added.
Okay. So let's talk about aortic dissections, because this is one of the most scary catastrophes that can happen that causes chest pain. What I've drawn here is there's the normal aorta, which is the biggest blood vessel that leaves the heart and supplies the rest of the body with blood. But what you can see is that there is a break point where the red arrow is. So what has happened is that the normal blood flow is going down the normal blood vessel, but a break point develops and the layer of the aortic wall, which has three layers to it, gets split apart. So it's literally being dissected apart and it's being unzipped like a zipper. And it creates what's called a false lumen. So what it's almost like is that the normal aorta is being encircled by a wall, an encased wall of blood. And so it's two separate channels, one being the area of the normal blood flow, which we call the, not the trolumen, the true lumen. I didn't proofread this well enough. And then the false lumen. Now, the problem develops because the false lumen, because of the pressure of each pulse of blood, it pushes and gradually dissects the, the aortic wall to split apart. The most disastrous consequence is if that was to rupture out of the aorta itself and cause the person to exsanguinate. But what else can happen is as this aorta is being dissected and this encircling of the normal blood vessel is being expanded, it can push upon the branches of the blood vessel that come off of the aorta. So you see up top that there's three red prongs that are coming off, and those are the branches of the aortic arch. The one all the way to the left is the one that supplies your right carotid and your right arm circulation. The one in the middle supplies your left carotid, and the one all the way on the right supplies your left arm. So that might explain why we get those different blood pressures. Once again, this is showing the similar condition, the similar event that the blood has gotten into this flap, this imperfection, and has caused the aortic wall to split apart. So this is what would be the purple is that those blood collections that are accumulating around the outer, it looks like it's accumulating around the outer wall, and it can completely encircle the normal aorta itself. So you can see if that encircling blood vessel compresses one of those branches, it's going to constrict it and it's going to reduce the blood flow going through there. So what is happening in this gentleman is his left arm's blood supply is being constricted by a thoracic aortic dissection. Thoracic aortic dissections are the ones where you will have the chest pain that goes around to the back. The abdominals, they do follow their anatomic distribution. A lot of times the aorta is located adjacent to the spine when it goes into the abdomen. So a lot of these people may not feel stomach pain, they'll feel primarily back pain. And a lot of times when people have aortic aneurysms, that's the pain that they primarily feel is back pain. So when somebody complains to me about back pain and I'm feeling something when I feel their abdomen and it's pulsing, I'm like, can we get an ultrasound real quick of what this aorta? I want to make sure it's not, that we don't have an aneurysm here. So an aneurysm is a weakening causing a enlargement of the blood vessel, but a dissection is one of the actual disasters that can happen. And with splitting of the aorta and the risk of hemorrhage and the risk of losing blood supply to the branches off of the aorta. Does that make sense?
Yeah, thank you for the explanation. And an individual asked, is this the same as SCAD? Now I'm not SCAD. I'm not familiar with
I
SC.
apologize. I have to look up what that is.
Yeah, I don't know.
Um, I may have to Google that. I apologize. It's been a while.
Spontaneous coronary artery dissection.
Okay. All right. No, that's
Yeah.
great question. Spontaneous coronary artery dissection is different because that is in the very delicate the endothelium of the inner lining of the coronaries. It's not exposed to the same pressures as the aorta. The aorta is exposed to very high pressures. It handles the full systolic burden. The coronary arteries actually fill in diastole, so they don't have a high pressure. Spontaneous coronary artery dissections happen primarily, one of the highest incidences in pregnant females because when women are pregnant, their soft their connective tissue relaxes, and part of the reason for that is so that when they give birth, their pelvis can dilate and their cervix can dilate to give birth. But it affects all the connective tissue. If you ever notice, sometimes pregnant women might waddle a little bit because their pelvis and their hips are hyper flexible. Well, that can happen also in the coronary arteries. So good question, um, but a difference between the two.
We say we should take a break soon. If there's a lot more with aortic dissection, we could either come back for that, or Steve, would you prefer to finish that here and then?
No, we can come back.
Okay, because there's some interesting things around traumatic aortic disruption as well to point out. So,
And we can also, when we come back, if people have questions about the other subjects we covered, we can spend a little time because we're going to have some time to answer those questions.
good. So we've got maybe what, 10 minutes? What do you recommend, Eric?
Yeah, let's hear it. It's 8:39. Let's take 10 minutes, so I'll round it off. Be back at 12. I'm sorry, wow, 8:50. So that's 10 minutes, and then we'll start up again. I will pause the recording, and I will start up at 8:50.
Okay. So, uh, are there any questions at this point? I can just proceed on otherwise, and we can do questions at the end, whatever works.
So let's see.
Nothing yet.
Nothing yet, just some thank yous.
Okay.
With that, so yeah, go right ahead and continue.
Okay. So, staying with the dissections, we're talking about now, this person had this at 32 years of age, pretty young. And his father died, quote unquote, of a heart attack, which basically means he died suddenly and no one really knows why. So, uh, this person also, this is a way that we image the blood vessels for someone who is having an aortic dissection. Although you have to be very careful. You don't want to stick catheters in this person because if you put it in an artery and the artery is torn, you could be putting the catheter into the wrong lumen. We call it the false lumen. So you could further split it apart. So, but this is injecting blood vessel dye into a vein, and then the blood flow is followed as it goes through the aorta. And what you see, the blue arrows have the lighter blood, and that means that more blood is flowing through there, and that's what we call the true lumen. And then the yellow is the false lumen. As you can see, the false lumen here is quite large, and it's almost like it's twisting around the true lumen. You see it, and then you don't see it, and then you see it because it's literally spiraled around the true lumen. So the true lumen is quite small. And this is literally a hematoma that is compressing the aorta and the true lumen. So this doesn't just kill you by rupturing, it can kill you by cutting off blood supply to different areas of the body. And obviously, stroke is a very big one as well. And so Marfan syndrome. Marfan syndrome is a disorder of the connective tissue in your body. And what is connective tissue? That's literally everything that holds your body together. It's everything that holds the body together, that holds muscles uh, to bones and bones to each other. The major component is collagen, and collagen literally is the major composition of most of the thicker blood vessels to keep them from bursting. It gives soft parts of the body their stiffness. And in Marfan's people, there is a genetic miscoding for one different type of collagen, and there's a number of different forms of it. It's called fibrillin. So instead of normal collagen, they have this weaker substrate. And so these people have their joints are very, very flexible. They grow. This is their stature. Their extremities are quite long. Their fingers are quite long. So these are fairly classical findings for someone with Marfan's syndrome. It is speculated, although we don't have proof, that Abraham Lincoln had Marfan's. He kind of has that body type, the tall, thin individual, big feet. But Marfan's people, the major thing that we have to worry about is aortic dissection and aneurysm of the aorta. And the major aneurysm that develops is in the upper portion of the aorta in the chest, the thoracic aorta. And the reason why is the area of the aorta closest to the heart absorbs the greatest pressure. Remember, it's the heart is pumping the blood, and the first portion of the aorta is absorbing the full force of that blood. So it's being stretched with every beat. So if it's soft tissue, it's going to stretch and stretch. And then because the inner lining of the aorta and the walls of the aorta are so fragile, they can be torn. So you've got stretching of the aorta as one problem, and you can have a rupture of an aneurysm, and then the other being the dissection. So these people have to be watched very closely. And once their aorta stretches to a certain level, they literally cut it out and they put in an artificial graft so that the risk of dissection is reduced. Some people end up having their entire aorta taken out and having graft material put in. And it's not all at once, but people can have aneurysms develop throughout their life. And so these people can have graft after graft. But Marfan syndrome, definitely sudden death can occur from aortic dissection. So this woman on the left side is quite the example. But I've seen Marfan's people who aren't quite this tall and spindly, but they have the problems with the aortic dissection. And so another form of aortic dissection is when the aorta is hit with a deceleration injury, with an impact, and that is another way that you can develop a dissection. You can develop a traumatic flap, And it can either, there's two ways that it can happen. One is the inner lining gets torn away, and the other one is a bruise can form within the wall itself. And we call that an intramural hematoma or in the wall hematoma. And if that has the perfectly wrong circumstances, it will spread or it will break through either internally or externally. And so this is what we see. And if it stretches enough, we get exsanguination. And Linda has had a couple of cases of traumatic aortic dissections, and she provided me with, unfortunately, someone who didn't make it, who had a pathologic specimen here. Linda, do you want to explain this? You do a better job at this than I did.
Sure. So this was a young man, I would say 20 years old, and he was a rower, and he actually had Marfan's syndrome, and he was actually struck in the back with an oar during one of his rowing events, and he first experienced like a traumatic paraplegia. For no reason, everyone was thinking that it was in relation to the hit on the back and maybe spinal damage. But in reality, what happened when he came into the trauma center, he had purple lower extremities, and he just became massively ecchymotic and immediately went into cardiac arrest. And upon autopsy, this is basically a piece of his chest that shows where the aorta was, and his aorta just pulled apart like a rubber band, and literally one end went up into the high into the chest cavity, and the other is here, and it's just showing that point of rupture, and it was just a snap. But the Marfan's syndrome really played a role in this because he had a much weaker aorta as a result of it.
Yeah, that's pretty devastating. And of these people, as I said, cardiologists know to watch these people very closely. We put them on beta blockers, which are blood pressure medications. But the other thing with beta blockers is they block stress hormones, they block epinephrine, and they soften the heart's contraction so that every heartbeat isn't as forceful. So the stress on the blood vessels themselves is reduced, and we like to get their blood pressure as low as possible without making them fatigued or dizzy or pass out to reduce the risk. And it's a real challenge sometimes. Marfan's is a scary diagnosis, and it's good to pick it up as soon as possible because it prevents the development of these aneurysms and then obviously the tragic consequences of an aneurysm rupture or a dissection. Okay. Scenario number 6, 21-year-old male, acute onset of left-sided mid-parasternal chest pain and shortness of breath. It was sudden in onset, just came out of nowhere. No change with position. Well, I shouldn't say that. He was exerting himself at the time, but but when he stopped, there was no change with position, no change with twisting. It was sharp, and he feels increased pressure when he tries to take a deep breath. It is focused in the lower left portion of his chest. It is causing pain when he tries to take a deep breath, but it's just also the effort of trying to take a deep breath that is causing his discomfort. The chest discomfort's a little lower than that, but that's approximately where it is. He's no drug allergies. He smokes weed 2 to 3 nights a week. He broke his arm at 15 doing a half pipe. He had breakfast this morning and he was exerting himself. He was climbing the stairs and had this sudden onset of shortness of breath and this chest discomfort. So when you look at this person, has rapid, shallow breaths, respiratory rate about 30. His heart rate's 112. Blood pressure is a little low, 95/60 bilaterally. And you kind of get the feeling when you put both hands on the chest to do that portion of the exam that only one side appears to be expanding normally. Oximetry is borderline at 90%. When you do an EKG on this person, and I know that this is not for everybody, but what this EKG shows is that there's been a shift in the position of the heart. So it's shifted to the right, and so the left-sided EKG, the left-sided leads aren't really picking up much of a impulse, a normal impulse. So we could say that the heart may have been shifted a little bit to the right side of the chest. So we did an X-ray, and on the left side, you see a normal X-ray, and on the right side, you're seeing a couple of things that look abnormal. One of the things I put was on the right lung, it looks hazy, and on the left lung on the right side, it's dark. And you also see that there is the diaphragm on the left side is also pushed down. If you look at the white arrow up above, that's the trachea, which is supposed to be in the center of the chest. It's supposed to be lining up with the sternum, and it's kind of over on the right-hand side. So that is the chest X-ray. And so what would you expect? What is an important finding on physical exam? And irregular heartbeat, unequal chest expansion, leg swelling, abdominal tenderness, clavicular deformity. Well, that might be, but that's not what's here. And actually on the X-ray, you don't see that. So unequal chest expansion. So what we see here, and we see this in younger individuals, is what's termed a spontaneous pneumothorax. On the left side, you see two well-expanded lungs, and lungs are basically two balloons that are contained within in a jar or a plastic container, and they're held open by the negative pressure between the container and the lungs themselves. So the lungs are literally held open, and if air gets between the lungs and what we call the pleural space, the lungs collapse and they become compressed. And actually, I didn't point that out in the previous one. There was where are you? And all the way, actually, mine is my Zoom thing is kind of in the way, but those white arrows on the right-hand side are all pointing at something, and what they're pointing at is the collapsed lung. So that lung has been completely collapsed, and so air has filled that chamber, and this is what can happen if you have a sucking chest wound where you haven't put the dressing on properly, so that air accumulated in the chest itself, and you developed a pneumothorax. So the problem here is not only that you've got air there, air in the lung, but it's also putting pressure on the right lung and it's putting pressure on the heart. And like if there was a large pericardial effusion, a tension pneumothorax can create a problem with tamponade of the heart, meaning that the high pressures on the heart can literally put them into tamponade. And so it needs rapid decompression, not only for oxygenation, but also.
Was on, if you would like, please let me know.
And also to return circulation. Now, why does it happen? We're not really sure. We think that there's unequal growth of the lungs, and maybe there's stretching, and with the stretching, asymmetric stretching, there's small tears that can develop. And if you get a tear in the lungs and air leaks out into the pleural space, that's when you start developing developing a pneumothorax. And the treatment here is, for this one, is obviously you have to stick a needle into it and to decompress. A lot of times, if they're small and you just see a small dark spot in one area of the lung, a lot of times we don't do anything. We just keep an eye on it because we assume a small leak developed and then it's sealed up. And we keep an eye on it to make sure it's not getting larger, because if it does get larger, then you do need to have a way of alleviating the leak and alleviating the pressure buildup. Okay. So I guess I can go back to the other scenario that I was going to talk about. We have some time, unless you want to spend it with questions. There you go.
Yeah. What's the pleasure of the group? Do you have questions you would like to ask Steve, or would you like to go back to that other scenario? Scenario.
Okay. So scenario, well, I have to go quickly past it so you guys don't
Close your eyes.
No, it's fine. These people are smart. They're going to figure it out anyway. So scenario number 3. Let me pull this. I've got my Zoom pictures here. I have to, actually, it doesn't want to move. Where are you? Oh, there we go. Figures. All right, now I got it. So 57-year-old, I mean, this is kind of self-explanatory. I'm not pulling any surprises here. 57-year-old complaining of a fullness in the mid-epigastric region and lower chest. Then it went up into the mid-sternum and became a chest tightness. It started as a pressure in the solar plexus and then went up into the mid-chest. Patient says, if I could just belch, I would feel a whole lot better. And unfortunately, nothing seems to relieve it. It's been 2 hours and it just doesn't seem to be getting better. It's described as a pressure, a fullness, and then it was an upper chest tightness. It continued, as I said. It started out in the mid-epigastric and lower sternum, and then it worked itself up into the upper chest. It started out as pressure about 5 to 6 out of 10, and then it became 8+ out of 10 as tightness in the upper chest. And the initial pressure started about a half hour after eating, and about 30 minutes later, it went on to become chest tightness. And this is the approximate locations of where the initial discomfort was and where the next discomfort developed. He has no significant prior medical history. He actually takes aspirin and Motrin as needed, and he takes some Prilosec as well for the occasional discomforts. He had a Mexican omelet for lunch, and he ate and had this about 30 minutes later. I'm not making this too subtle. Um, he can't get comfortable, and he's got a clenched fist over his mid-chest. His blood pressure is 160 over 90 bilaterally. His pulse is 108. His respiratory rate's 24. He's uncomfortable. SAT is 96. He's trying to belch, but he can't seem to improve. His abdomen appears a little bloated. Here's his EKG, and I say hint, it's normal. So that's not helping you a whole lot. Here is his chest X-ray. And I'm making it easy for you as I'm showing you that there's a gastric bubble there next to the heart. And gastric bubbles generally are where the stomach is. So why is there a gastric bubble there? Any thoughts?
People saying GERD. Haven't seen anyone actually naming the problem specifically yet. I'm seeing, yeah, well, you want to say that?
No.
Okay. Oh, someone just did. Hiatal hernia.
There you go. Ding, ding, ding. So there's two processes going on, and because the hiatal hernia itself would not explain the second portion of this. And it's a hiatal hernia is what you're seeing. We'll come back to that. So here is what a hiatal hernia is. On the left side, you see the normal stomach. The normal stomach sits completely underneath the diaphragm, and diaphragm is what divides the stomach from the chest. What happens with a hiatal hernia is a little bit of that stomach slides up into the chest. And with that stomach sliding up, there's acid and gas and gastric contents that come up with it. And it is constricted, so it can't alleviate the pressure. So you've got this pressure sensation and you just wish you can alleviate it. It can go up through the esophagus, and some people actually vomit if it's that bad. But most of the time, people will just wait for it to decompress, and eventually, in a lot of these people, it will slide back down. We call it a sliding hiatal hernia. It will slide up into the chest, particularly after a big meal where there's a lot of pressure in the stomach. Is not enough room in the abdomen, so it will slide up into the chest. And so the constriction around that neck of the hiatal hernia is what causes the pressure and the discomfort. And that's more in the lower the lower chest. What also happens though, and people are talking about this, and so this is just a barium swallow of someone who is suffering from a hiatal hernia. The normal gastroesophageal junction, that should be where the diaphragm should be, which is where the chest moves down into the abdomen. But it's a little high up here because you could see the diaphragmatic constriction on one side, the gastroesophageal junction on the other, and there's the hiatal hernia, which is that trapped stomach portion that can't seem to slide back down just yet.
So there is a question of whether GERD and a hiatal hernia exist together.
Yes, great question, and that is true. Because you increase anything that increases pressure in the stomach can cause reflux into the esophagus. And so definitely this is clearly going to increase pressure in the area between the stomach and the esophagus. one of the things that happens when you chronically get a lot of reflux, and this is where the next portion of the uh, scenario is this is where the gastroesophageal reflux occurs. The esophageal sphincter is what keeps the stomach contents into the stomach, and sometimes the sphincter on the right-hand side isn't strong enough to hold back the reverse flow, particularly if you've had a large meal, or you're a big acid producer. And if it is chronic enough, it can cause spasm of the esophagus itself, because the esophagus literally, if you're familiar with the term peristalsis, that's the process by which food is passed down from the throat down to the stomach through the esophagus, and it sends smooth muscle contraction. Well, if the esophagus is really irritated, well, then all the smooth muscle contracts, and that's very painful. And so that's what we call esophageal spasm, which is what you see on the right-hand side. The entire esophagus is a bunch of kinks, and that can be very uncomfortable. And the tricky thing with this is, guess what nitroglycerin does to this discomfort? It makes it better. So you've got someone with chest tightness, closed fist, and you've given them nitro and they're feeling better. And I'm like, well, I guess you're going to have to bring this person to the hospital because this could be their heart. But this is one of those imposters. It doesn't mean that if you have somebody, you give them nitro and all of a sudden they feel better. Oh, it's esophageal spasm. Clearly that they need to have their EKG, they need to have all the appropriate testing. But yeah, this is one of those where chest discomfort can be alleviated by nitroglycerin. I think, is that it? Oh, and this is one that I'm going to let Linda explain, because I said, is this a hiatal hernia, Linda? And she had a very funny response to this. So I'm going to let her explain it if she doesn't mind.
Now, I was asking the question if this really represented a diaphragmatic hernia or a ruptured diaphragm, essentially, where in a trauma, the diaphragm ruptures and the stomach just gets kind of sucked up into the chest cavity. And so you can imagine a person comes in, now their stomach is in their chest, obviously shouldn't be there, and the person's now really short of breath. And then you have some very surgical resident where they haven't maybe done a chest x-ray yet. They're thinking, oh, this is a tension pneumo, whatever. And they stick a chest tube in blind, and then you stick a chest tube in the stomach. And what comes out of the chest tube are in fact Wheaties. So that's not a good day.
Yes. And let's hope that everybody checks chest x-rays when they hear decreased breath sounds before they think before you act.
And of course, one of the tenets of trauma care is you're not necessarily always getting a chest x-ray first, right? It's a
Right.
diagnosis. So, this is one of the challenges in the event you have a ruptured diaphragm.
Okay. Well, it's always good to have curveballs thrown, because it just makes you we don't in first responder medicine, you have to have fast reaction times. You have to respond to the crisis. You have to have your quick algorithm. And sometimes things that don't fall into the neat algorithm get missed. And so part of what I'm doing today is showing you, well, these are things that you could think about when somebody's having chest pain and it's just not adding up for you. And to be able to recognize patterns, to be able to use your assessment skills, sometimes you can uncover things that are not the heart. So as I say, when it comes to chest pain, don't only blame the heart. Give the heart some respect, just like Rodney Dangerfield. Okay, let's see here. Is there anything else? I can always ask those questions that I had at the end.
Yeah. Can I throw in two things real quick
Absolutely.
regarding aortic dissection? So, in the trauma world, so two scenarios particularly with our patrollers out there and EMS providers. So someone goes off a big jump, right? So they're landing, on their skis or snowboard, whatever. They're taking a long fall, basically from a height. They can actually dissect their aorta as a result of that. So you can tear at the aortic root. That would be the pattern of injury that you would see in the event it was an extremely traumatic jump, right? So whether it's a feature or some other natural thing they're jumping off of. The other way would be slamming hard into a tree. And in the EMS community, that could be a car crash, motor vehicle crash, head-on collision. And there, you're actually tearing right at the subclavian artery and the aortic arch, and you can produce a dissection that way. So the discussion around aortic dissection has both medical and trauma connections. That's all I wanted to say. Thanks.
If you, I'll ask a few questions and which one is not associated with chest pain that worsens with respiration? So what's chest pain that worsens with respiration? We call that pleuritic chest pain. So which one of these is not made worse by respiration? Okay.
I'm seeing reflux.
Reflux.
Lots of
Very
reflux.
good. Yep. You were paying attention. All right, this is just this one. This is for the previous lecture, so we don't need to go with that one. 72-year-old man is having chest pain with hand covering the left chest. What is the likely location of the pain?
Anyone? Seeing precordial, lateral.
I'd say lateral is a fair guess, but precordial is covering the chest. So like you have the precordial leads, the leads over the chest. So I would say precordial. Which of the following cause of chest pain is never associated with a normal EKG? Never associated with a normal EKG.
I'm seeing MI, costochondritis. Again.
I know it's kind of a double negative here, but what's that?
I'm seeing people pericarditis. These are the responses in the comments to costochondritis.
So I'm going to be a party pooper and say that a normal EKG can be seen with any of these diagnoses, even of myocardial infarction, because with a standard, I'm sure EMS folks are aware of the fact that, with a standard normal 12-lead EKG, you can miss certain myocardial infarctions that occur around the posterior distribution. The others, definitely you can have normal EKGs. Just because you're having pain doesn't mean it's going to be reflected on the EKG itself. So a lot of times your story, your history is important. And if someone gives a history that sounds like an MI and I got a normal EKG, well, I'm going to say, well, I I am concerned and I'm going to pursue the tests. We check what's called cardiac enzymes. And the other thing sometimes that you do, and this is you repeat another EKG maybe about 10 to 15 minutes or 20 minutes later to see if there's been any change. And that's particularly important in somebody who's having a myocardial infarction. We always get repeat electrocardiograms. You don't just stop at one. But it is possible in any of these situations that you can have a normal EKG. Let's see. Which cause of chest pain is often associated with long distance traveling?
I'm seeing lots of number 2s.
Good. That's the answer.
Pulmonary.
Of course, if you're sitting there in an uncomfortable position and you've slept the wrong way, costochondritis can happen because your chest is all out of alignment. But no, it is pulmonary embolism. Very good. Let's see. This is okay. So this is all right. This is the last one, but this is one from the last lecture, but we'll just say it anyway. So EMS is dispatched, 67-year-old female who has had 15 minutes of chest pain after climbing stairs. Upon arrival, 5 minutes later, the chest pain resolved soon afterwards. What is the most likely diagnosis?
Seeing lots of number 4.
Yep.
Very sharp group.
Okay. You're clearly I can't pull anything over on any of you. I take back that situation about you guys not being medical professionals after this lecture. You clearly are all very qualified, and I'll call you all for medical advice.
We do have one unanswered question that actually preceded your questions that I'm going to throw out, and it's, can COPD cause chest pain, and are there any specific chest pain symptoms of COPD?
Great question. COPD can cause different chest pains depending upon there's a couple of different mechanisms. The bronchospasm, like what you might get with asthma, that can cause discomfort. When sometimes people, just the force of coughing can cause pain. A lot of times that's chest wall pain. But it really, the COPD pain is more the effort of trying to breathe. The blue bloaters, the pink puffers, they are working extra hard to breathe. So the muscles of the chest wall and the rib cage, the intercostal muscles are all working hard to breathe, and a lot of times it's just the effort itself that can do it. And also bronchospasm, turbulent airflow through the lungs also can cause it. And one of the other things is if somebody is having an asthmatic exacerbation, sometimes, and I know this sounds crazy, nitroglycerin actually might help because it's a smooth muscle relaxant. So really with the COPD, the chest pains that I tend to see though are from effort. It's from from having to exert effort to breathe more than anything else.
Yeah, we're at our time actually, but there is a remark about pink puffers and blue bloaters, and there may not be people who are familiar with that. So certainly something I learned about long ago. But Steve, if you want to describe pink puffers and blue bloaters.
Okay. Pink puffers refer to people who have emphysema. They have hyper stretchable lungs. And they tend not to be so much hypoxic, but they have they have to really work their lungs to breathe, because generally these people have very stretched out lungs, and trying to take a deep breath for these people whose lungs are already stretched out is very difficult. So they can only take breaths, they can only breathe small amounts at a time. So their chest is hyper expanded. They're pink because they usually have enough oxygen, but they're expending so much energy trying to move air in and out of their chest, because they've got their lungs are too elastic. Blue bloaters are people who have obstructed airways. So they have problems with what's called air trapping. They have problems with airway obstruction. So they're not getting enough oxygen into their lungs, and they are the ones that have chronic bronchitis. So they have I'm not giving the best descriptions, but I'm doing my best to say these are people that struggle with bronchitis, with airway obstruction. Their problem is not with elasticity of the lungs, it's quite the opposite. It's the stiffness of the lungs themselves.
They tend to
And
be a lot more cyanotic, which is why they get the term
yeah,
balloon. And they tend to
yes, they tend,
yeah,
right.
the barrel chest, and then the pink puffers, they often are skinny, interestingly, and the blue bloat
Yes,
a little heavier, and the pink puffers tend to have a more of a ruddy complexion. They get a lot of airway damage, and as you described, and alveolar destruction.
right.
Very different.
The,
So, but so Eric, I'm
Uh,
seeing comments coming in, very informative. Thank you. Lots of great stuff.
all right. Well, if we don't have any other questions, let's call it a workshop. Again, thank you everybody for attending. I will get the certification of completions out. For those who are in Pennsylvania, with an EMS certification goes right into your account. Everybody else, I will get an email out to you as soon as possible. If you don't hear from me within like 2 weeks or so, email me. I'll just double check the roster. I might have missed you as I was going through everything. Otherwise, thank you again. And we all look forward to you for the next one.
And Eric, did you mention about YouTube? You mentioned about YouTube, right? The fact that this was
Yes.
YouTube.
So in the link, I put the recording from the first assessment of chest pain Pator workshop from Dr. Goldblatt. So if you missed the first one, it's in the links us on YouTube under the Bear Creek EMS program channel, along with all of our other recordings. I think except for one, due just to HIPAA. But other than that, we are good. Sorry, not HIPAA. It just there was an issue. So, all right. Call. Thank you again. Call it a day.
here, everybody.
Steve,
Thanks
I did,
for
Go ahead. I'm sorry, Larry.
Steve, I did